am coming on here because I wanted to give you an honest and raw update. Well, it's not really an update because I haven't really told you anything, but I've been trying to get pregnant with a second child. And it's been a really different journey so far than I imagined that it would be. I went in, I was already nervous because my body is a completely different body. All my organs were taken out when I had a traumatic C-section. And so I went in to do a transfer via IVF, to prep my body for it, which responded totally differently than it did the first time. And we did an FET, a transfer, and it not only did not work, but it actually ended up becoming an ectopic pregnancy, which is a pregnancy that happens outside the uterus that you don't usually know where it is. And it's really dangerous and it's really scary. And I just wanted to be real and honest about that. Since then, I've had to have multiple different procedures. I had to have tissue taken from my uterus. Before that, we thought there was a polyp around my uterus. It has been really difficult, and I'm not emotional as I share this now because I've been through it already. And I am trying to be positive and manifest positivity now for when we can do another transfer. And I'm hoping that things will go well. And I think part of why things didn't go well the first time was because my attitude was like, oh, well, it's definitely not going to work this time because it didn't work because it worked it worked on the first try the first time. So it's not going to work this time. And I think I was just talking to myself in a way that really wasn't productive at all. And also after the transfer, I actually ended up getting norovirus, I think a day or two after. And I'm not saying that that's the reason it didn't work, but that certainly did not help. And I think, I was blaming myself a lot for that not working. And it was really hard. And so on this episode today, I actually have my fertility doctor coming on, and we're going to be talking about the journey so far. But as always, I feel it's so important to be transparent with everyone. And if there's someone listening who's gone through something similar, you're not alone. And it's really shitty. And it's, all these kinds of feelings come up and you're like, oh, why can't I just be someone that can get pregnant on my own? Or, why can't it be as IVF be as easy as it was the first time, or this or that? And I think it's a little different this time because I feel very grateful to have a healthy baby at home. But then it's also a mix of emotions because I feel almost like I'm not allowed to be upset about this not working. Because I should be just so appreciative of what I have. So it's a roller coaster, and it has been. And I just wanted to share that with you guys, and I hope that you enjoy this episode today. We're busting a lot of IVF myths, and I also wrote a Substack on the whole ectopic situation, so I'm going to link that in the show notes as well. And if you've gone through something similar, please reach out. I would love to hear about it and talk about it. Hey guys, welcome back to We Met at Acme. I'm here with a repeat guest,
Woo!
Dr. Catha Fischer. Hi.
Hi. So happy to be here.
I'm so happy we coordinated with ketchup and mustard.
I hate ketchup and mustard. I feel like this is a party foul.
Do you actually hate ketchup and mustard, or you hate the colors together?
I hate brown and black. I hate brown and green because it's like a tree. I hate yellow and red because it's ketchup and mustard.
Yeah.
I have orange and green. No, it's like a pumpkin.
What about green and purple? Because of Barney.
Agnostic. Barney.
Yeah.
No, I don't like it. That's a good
I
point.
really miss Barney. I'm sad that my child isn't growing up with Barney. Did your kids have Barney?
They did not, but my husband has made them watch Pee-wee's Playhouse, which feels real weird.
Isn't he like arrested?
He's also dead.
Or dead.
But all the things.
He's dead and arrested.
But I think he was a genius, but it's too weird for me.
Right.
But my husband really likes it.
It's a little weird.
It's a little weird.
But I might have to look that one up because we've overdone Miss Rachel. So
What's Miss Rachel?
Oh my God, you don't know?
No. No.
Bless you. You don't need to. I'll tell you after.
Okay.
So before I am bringing you into the episode, I was talking a little bit about how my journey has not been linear. And it's so interesting because when we started working together again for what hopefully will be baby number 2 at some point, knock on wood, I had said to you like, oh, I just don't know if it's going to be as easy as the first time. And you were like, wait. It wasn't easy the first time. Like, do you have baby brain? Like, you don't remember. And so to the outside world, it does seem like it was really easy. It seemed like I got pregnant on the first time, which is technically what happened.
Yeah.
But why did you say that it wasn't?
So I feel, and this is so common, that people, if things work out, they just assume that everything went to plan. And truly, I would say 85% of my job is like audibles. Like, how do I manage this? What do I need to do? And your embryo transfer cycle for Zach did not go to plan. Remember, we tried to do it a couple of different ways before, like, okay, we got to try like this approach. And that's really common. And you just don't remember any of it because it worked out and it was fine. But we were concerned about lots of things in that moment. And I'm thrilled that everything is fabulous. But that is so common. People just assume, hey, it was great before, it's going to be great again. And also it sets you up for like disappointment. And then any failure feels like the biggest failure because it didn't go exactly the same way as like your first cycle transfer, whatever it is.
Right.
So I try to kind of forecast and say, hey, it wasn't like that great the first time. And sometimes patients are like taken aback. Like, what do you mean? Like, you didn't say that before. I'm like, no, I definitely did. It's just what you kind of remember. And you do have like baby brain, pregnancy brain. But that it's just everyone thinks that.
Yeah. And not that we have an exact statistic, but obviously, you know, for background, I didn't mention before, Dr. Fischer works at Spring Fertility, which is my place. And thank God I found you guys. But at Spring, is there sort of an idea of how many of these go to quote unquote plan? And when I say plan, I mean like how, you know how a prenup is a standard prenup, right?
I mean, I don't have a prenup, but that sounds nice.
I mean, I have an embryo prenup. But
as everybody should. Yeah.
But a prenup standard is that, you know, when before you're married, everything is your own. While you're married, you end up, God forbid, if you're divorced, you split everything during the marriage 50-50, right?
Okay.
And if you make amends to that prenup, it's like a little, it's a little sus, you know, as the kids say.
As the kids say these
And
days.
actually, it's so funny. I wrote this in my sleep last night. I was like, I have to bring this up to Dr. Fischer. So I'm going to find the note that I wrote. So I had written, what does a standard IVF journey look like for someone with no other issues, right? So we're talking no PCOS, no endo. Is it similar to a standard prenup in that there's a standard that is believed, and then if you veer from that, it gets like kind of...
Yeah. The answer is yes, right? There are always averages amongst like clinics and centers. And I tried to, like my first visit, kind of forecast that this is like what to expect. Also from like an accountability standpoint, this is where we're at right now. And so if we veer from this, we have to talk about it and we talk about why. Embryo transfers are a little bit different because we really just talk about whether like it's successful, as in like, is there a live birth? We don't necessarily talk about like along the way, do we have to like take a couple different like turns? So it's an interesting question. I don't know. What I can tell you is I don't often cancel a lot of embryo transfers. You try to kind of like work your way through. But if any of us are at the point where like, this is just not going to lead to success, then of course you cancel it. But usually there are many different ways to approach it, right? There's like a modified natural cycle, which means you're taking oral medications to try to help your body grow a couple more follicles, but the lining's being built by your natural estrogens and you're kind of still ovulating and we're tracking that.
That sounds like the standard.
That is our standard at Spring Fertility. It is not the standard, but there's a lot of fantastic research now, and like robust research to suggest that it is better for pregnancies, not success. And so from a natural cycle, you have a lower rate of like preterm delivery, preeclampsia, which is like high blood pressure, what like Kim Kardashian had, and like gestational diabetes. And it has something to do with the fact that like your body's making natural progesterone. The challenge with that kind of cycle is it's kind of cumbersome for the clinic, honestly. You have to have people come in whenever their body is ovulatory or periovulatory and make sure that we are timing everything right on. Centers that aren't open 7 days a week, centers that can't accommodate transfers willy-nilly, that's challenging. So a lot of, I would say, still standard is like a program transfer, which means you're taking estrogen, whether it's oral medication, patches, vaginal suppositories to build the uterine tissue. And typically you're doing that for like 12 to 16 days and then starting progesterone shots. Progesterone shots are the worst.
The worst.
I
So
think.
if someone doesn't have a hormone condition,
Yeah.
would you still have them back it up with estrogen and progesterone just for peace of mind?
It very much depends on what the body's doing that cycle, honestly. So I make those decisions based on like the follicle sizes I'm seeing and your hormone levels on that day. So I will often say, actually, I think she benefits from taking some estrogen on this day or progesterone suppositories. So a lot of that really honestly is pretty individual. And I will call those shots like as we go. Very typically, you're not starting with all these medications. It's like as we're progressing, I'm thinking, oh, I think her progesterone's going to be low because she has 1 follicle instead of 3 follicles. So let's make sure that like it's supplemented enough.
Mm-hmm.
There isn't necessarily a perfect for this. It's like what's perfect for your physiology and body. And sometimes I had a patient really recently. She had a tough time getting her first pregnancy, had miscarriages before me. We made chromosomally balanced embryos. We thought this is going to be it. This will really help us. And then she had 2 failed embryo transfers. And her third one, we did what I call like the voodoo protocol, which is not evidence-based and taking like steroids for suppression and like baby aspirin and lots of different things. She got pregnant, had a beautiful baby. She comes back and she's like, I want to do that protocol again. I was like, you're a whole different human. Like you're a whole different uterus, whole different everything. But she just couldn't let that go because it worked. So we did it. It didn't work. And then we did like our typical like vanilla hands-off protocol and she's happily pregnant at like 10 weeks.
And that's the thing, right? And I think I had this problem too when I came in the second time. And definitely in Steven's mind, he was like, whatever we did, we have to redo. And when I went in for my transfer for the first time, the second time, or the second go around rather, I like wore the same sweatshirt. I did the same. And it's, you get so crazy about this stuff. And it didn't work. You know, it didn't go as planned, as we know and as I've shared about. But it's so hard not to blame yourself. And I'm sure it's not just me. I'm sure it's every single, person that comes in that doesn't have a successful transfer or has to have a procedure in the interim or something. It's like, how do you tell them? I know you're not a therapist, even though you're really good at it, but how do you tell them not to blame themselves? And how can you kind of tell our listeners listening that it's not their fault if a transfer doesn't work?
It's really hard. And I try my best to sort of forecast emotions that I think may come your way and quickly put them like to the side and say, don't think this and don't feel this way. It is almost inevitable. All of us want to be in control of like outcomes, destiny, if you will. And then if something doesn't work out, the easiest thing to do is like self-reflection, figure out, what did I do? Did I have like too much coffee? Did I pick up like my son? Did I work out too hard? All of these things. And none of them matter at all, short of like getting into a car accident, right? Nothing is really going to change an implantation. And so understanding that there's no control there sometimes is really freeing, but other times is like really just makes you want to just shelter and like stay in one location for the 10 days that you're waiting.
Right.
But everything that you were feeling is so common, which is a part of why I was like, we have to talk about this, because every single patient I have quickly goes to like self-blame and what did I do to like make this not work out, or why didn't it happen the way it happened before. And it's just every day is different, every cycle is different. You're still going to get to the finish line, it's going to work out, but having faith and belief is really critical. And then also, this is where I think having a real relationship with your team is really important, right? Because if you didn't trust me, then the first thing you do is doubt me, actually. And you're like, what did she do that was different here? And it's, there's no doctor in the world that doesn't want things to work out, like ever, right? But I can tell when I talk to patients and I say, this isn't your fault. If they flip and say, no, it's yours, I can tell.
No.
For sure, because people are, you're not at your best self.
Right.
And I try to have as much empathy as I possibly can, give everyone grace. And I truly try to not take it personally. I'm probably worse than most with that. I do like internalize things.
I was going to say, do you ever blame yourself, even though you actually know that you did all the right things?
I blame myself for a patient blaming me, if that makes sense. Because I feel like I've missed the opportunity to show them how much I care and like how much attention I'm paying. I rarely like truly blame myself, like, oh, I wish I'd done this or that, because I don't know. I'm sure I do that too. But mostly it's, I feel like I've lost them somehow. And like, where did I go wrong there? Not And I don't think it's like I ever feel like I missed something. I'm sure I have in the past, but it's mostly I'm like, oh, why do they feel that way? And how can I make them feel better about this so we can get to the finish line?
It's so interesting because what I noticed through this process not working this time, and even before we were able to do the transfer, you wanted me to check every nook and cranny out.
Yeah.
You wanted me to, oh my God, could this be that?
Yeah.
What about this? Can we get some tissue from here?
Yeah.
Like there was just no stone left unturned. So I feel like knowing that you wanted me to do that, even though you knew that it would be annoying for me to do, obviously you're not doing it to be annoying.
Right.
You're doing it to make sure we're set up in the best case scenario for a transfer.
Yeah.
So I imagine if someone were working with you, they would understand that like all of this stuff is to make sure that, you know, you're as set up as best as possible. But I think I agree with you. Like you could be in a really bad way if things, you know, continue not to work out.
Yes.
And
the internet is no one's friend. I mean, you even texted me and said, what about this test? Right. Like there's so much out there without any real like data or science that is just directly kind of sold to customers. And then it invariably will come to us and we'll have to sort of refute and say, this is why we didn't do that or think about this. And it speaks to, if you trust me, like, oh, that makes sense, fine. But if there's something kind of lost in translation, then you're thinking, well, why didn't you do these tests? There's no test out there that's validated to help us understand why embryo transfers don't work. It is like the black box for all of us. If you have this embryo that's screened, is chromosomally balanced, a uterine lining that is optimized, why doesn't it work 100% of the time? And that is everyone's like biggest pain point, right? Truly.
yeah, I mean, it's also so crazy because my lining was technically better the second time than it was with Zachary.
Yeah.
And that just worked and this didn't. And sometimes like at the end of the day, it's the same thing with when you get pregnant naturally. Like sometimes it stays and sometimes it doesn't. Sometimes it's a chemical pregnancy. It's not an IVF thing necessarily.
No.
And I feel like that's also going back to kind of people blaming themselves. When you get pregnant naturally, and again, I hate the word naturally.
Spontaneously. Yeah.
You are out drinking. Maybe you're even doing coke. Like who the hell knows what you're doing?
Oh my God.
And these pregnancies stay, you know, you're like riding upside down on like a carnival ride and these pregnancies stay. And but I think there's something about doing IVF where you are just like already so nervous that you just don't want to mess it up. So it's not worth it to be stupid. And I will say, and I'm not blaming myself, I promise I'm healed from that. But like I truly think that I did get cocky. Like I did. You were like, don't work out. I was like at Barry's the next day. You know, I, of course, traveled.
I didn't say don't work out. I said don't do more than you typically would do.
Yeah,
like you're typically a crazy person.
No, but I'm crazy. And so I went to Barry's the next day. I went to Philadelphia. I got norovirus. I did the whole shebang.
Yeah.
Okay. And then it didn't work. And
are you skipping the part that you were in Florida?
Well, no, that's coming up.
That's coming up. That is, ladies and gentlemen, the worst part of the story for my heart.
Well, so I got quote unquote pregnant, but you were like, it's not looking like it did before. We went back in 2 days later. It's still like the HCG level had gone up like maybe a point.
I didn't think to say don't go to Florida, just for the listeners out there.
Because Dr. Fischer had no idea that I was planning to go to Florida. And the next day I go to Florida. I'm staying with my in-laws and we're having, I wouldn't say it's a good week considering I just found out my transfer didn't work.
Right.
And there was no sun.
Yes.
But they were wonderful. And I'm like halfway into the week, Dr. Fisher's very standard, like, all right, so come in tomorrow. We'll check your blood. We just want to make sure like, you know, whatever's there is gone.
Yep.
I'm in Florida. You were like, what?
Yeah.
I don't
it was a Saturday. Yeah, the result came in 24 hours late.
And I don't think I'd ever heard you be so seriously scared of Florida. And understandably.
I know.
And it was the funny, you have to laugh in retrospect. Thank God I was okay. Right. But you were like, you cannot be in Florida in the state that you're in right now. Yes. And this was before we even knew that it was ectopic.
Right. We just were suspicious. And I was like, you have to get out of Florida.
Yeah. And I don't even know how you had that thought to think of that.
Because like ADHD levels or hormone levels should follow a specific pattern. And so when they veer a little bit, you're nervous. You're
Right.
thinking like, and we talked about, it's like, there are 3 ways this is going to go. And I said to you, the least likely way is ectopic. Egg on my face, right? Like, of course. But then when you were in Florida, it's like, this is now the most likely way, and you have to get back to me. You can't be in Florida.
You're like, you got to get home immediately.
Yeah.
Thank God I was on the flight the next day.
You were fine.
And everything ended up being okay, but it was really scary. And I will say that in this case, IVF was a blessing because an ectopic pregnancy can be extremely dangerous.
Yes.
And thank God for having done it through IVF, we were able to figure it out as soon as we could.
Yeah. That's the thing. It's ectopics are really scary. There are a few things in my field that I am afraid of. And ectopic pregnancy is one of them. Because that is something that can really put your life at risk. So if a pregnancy, ectopic just means growing outside of the uterus. And depending on where it lands will depend on how like proficiently it can get blood supply. The most common location is the fallopian tube, which is a tiny space, but it has blood vessels. And so if pregnancy gets stuck in there, it can get pretty big pretty fast. And most people, you have a positive pregnancy test and you see your OB at like 8 weeks. So you don't know in the interim, like what's happening with the levels and what's going on. For our world, we're checking so early that even ectopics typically are okay. That doesn't mean that anyone should go to Florida or anyone else and like while they're waiting. But usually it's not the scary, dangerous thing as long as you're like all over it the way that we were. But it's still frustrating. It's all of the things I'm sure you already talked about. It's really hard. Ectopic pregnancies are really hard because it worked. It's like, well, why did it not end up in the uterus? Like, what's going on?
Right. And then we really didn't know where it was.
No.
And we took, so we did a procedure after where we took some tissue from the uterus.
Yeah, exactly.
Is that technically a DNC or is it a DNC's cousin?
So a DNC stands for dilation and curettage, so dilation means you open the cervix, and then curettage means you're basically like typically it's like a metal instrument that is just scraping the uterine lining, and you're gonna send that off for analysis. Nowadays, most fertility doctors do a variant of that. That's what I would call like much more gentle. It's like a plastic catheter, and so there are no sharp edges because you really want to reduce any sort of risk of scarring. So we did that. We did like a manual uterine aspiration, which means it's like a 10-15 minute procedure where I remove the uterine tissue to basically prove the pregnancy is not inside the uterus. Because typically ectopics for fertility purposes, you don't see the pregnancy anywhere. It's so early. You're just sort of trending the hormone levels and going, these don't look 100% normal. What's happening? So we took the scant uterine tissue out and basically then sent that off for assessment and drew your blood the next morning. And if the pregnancy is inside the uterus, the blood work falls really quickly. And if it's outside the uterus, it kind of stays the same. For our purposes, we found out the tissue had no pregnancy in it. So we knew that it was confirmed it was an ectopic pregnancy. But in your case, and you can add this if you want to, but in your case, your body was able to squish the pregnancy on its own, which is so rare that ectopics self-resolve. But if they do, it's because the levels are low and your system's like, it's not where it's supposed to be. I'm going to inhibit its growth. And you had that happen, which is incredible. And I think I even said to you, your body did an incredible thing, right? This is unbelievable that it was like, this isn't healthy. No more of this. Because typically you're taking a medication that essentially sets you out of like conception for 3 months, which is just like salt in a wound, essentially. But oftentimes that's what I'm doing to treat these early ectopic pregnancies.
Yeah. Yeah. And after that, and I don't know if this was intentional or just happened, but we took about a month off. And again, you tell me if it was intentional, but it was like a really necessary month for me. I felt like I got back into shape. I wasn't thinking about it. And I think that's something with IVF that we don't allow us to do, like ourselves to do, because we're in such a race. Because usually when we come to IVF, we're like, I need to be pregnant now. That's why I'm here, you know? And I think obviously, you know, having Zachary was part of that, but also knowing that like my body needed a second.
Interesting. Yeah. I mean, everyone is really different. Some people just want to keep on going if they can. From like a success standpoint, it makes no difference. As soon as your body's hormonally reset, it's reset. So whether you do it a day after or 4 weeks after is irrelevant when we think about like outcome. But I try to understand, like, would it benefit you or a couple to take a beat? Would it benefit you just keep on grinding? Like, what's the right approach? Everyone's really different, but I do think the couples or the women that feel like they have to martyr themselves for fertility are really the population that suffers when things don't go exactly to plan, because it feels like those people that are like are not working out, not having like any glasses of wine, swallowing like 15 supplements a day, everything in the name of this outcome. And if it doesn't occur, it's really like shocking. So that's a group I will constantly sort of say, peel everything back, take 4 to 6 weeks away from me, and like, let's try again at that point. And I think they come back in like a better headspace, because that's a tough, it all goes to like control and self-blame. Like, you're like, if I do all of these things, it must work, because look at how much I've sacrificed. And that sucks then when it doesn't.
Yeah. It's like, okay, fertility is like dating. Hear me out.
Oh gosh. Okay. All right. I'm ready.
If you put all of your eggs in one basket of one man and it doesn't work out, you are devastated. Like fertility, if you put all of your eggs, no pun intended, into the idea that this is going to work, it has to work, and you don't have a backup plan. And I literally mean a backup plan of like, I'm going to go to a whole sushi dinner if this doesn't, right? Or I'm going to get a little Botox if this doesn't, or something minor. I always tell my friends going through fertility journeys, have something to look forward to if this doesn't work that you couldn't do if you had gotten pregnant.
Yeah, that's great. I think that's fantastic advice.
Like, even if it's just little, and like, I know it's like, you don't want to spend money because you're spending all this money on IVF, but then do something little. Make your, husband or boyfriend like make you dinner every night. Something that you're looking forward to. If this doesn't work out, I want this. Then it's a win-win. I mean, it's a lose, obviously, but you know what I'm saying.
Yeah, no, I do. And I think that's really important to have something else to look forward to. I think that's really, really good.
I wanted to get upper bluff if it didn't work the first time with Zachary.
What? Aren't you too young for that?
So technically, I think you're supposed to get it when you turn 40 if you're a candidate, but my eyes and
you don't have
great
to agree. Eyes.
But my lids are so heavy, just like that's just genetic how I was born, that like eventually they will cover my eyes and I will be blind. So honestly, insurance might even cover it.
I don't believe that's actually like facts in medicine, but
it's a hooded eyes thing.
Okay. I mean, now I feel like I need an upper bluff. Okay.
No, you're perfect.
Please,
you're perfect.
Please, okay.
Okay, let's bust some IVF myths. Oh, and just to close the loop on that, obviously we're looking towards the future now. We're resetting. We're going to see, hopefully the next transfer works. All we can do is put good juju out there, and hopefully I'll be back with some news soon.
Exciting. But so your question about like outcomes averages, this is a good point. When we talk about like embryos and embryo transfers, we meaning like fertility doctors would ideally have 2 available embryos for every pregnancy that you want. And so part of the conversation when we're doing an IVF cycle or fertility preservation is like, what's the strategy I need to employ for you to have like the outcome that you want? And sometimes what's challenging is that people have like 2 embryos, but they want 3 kids. I'm like, guys, like I know this feels great right now, but trust me, like pause, make more embryos, and so you have everything you need in the future rather than get like really excited and pregnant right now. And that's always, it's a conversation, right? But understanding family size goals and timeline is really helpful for any doctor and for me to like do my job well. But we can't sleep on like the luxury of having embryos and how like hard this is if you have 1 embryo available, it doesn't work, and you have to start like the whole process again. And know that that is like a difficult situation, but it's all manageable. And the like wonderful thing I think about IVF and fertility is there's always opportunity for like new cycles, right? And new follicles, new eggs, new embryos. Costs are always a problem, obviously. But if you're in a situation where you're like out of options, out of embryos, no one here should feel like they're up against a wall. It's just like, again, your head back together, figuring out like what's your best path forward. But sometimes it's not as straightforward as, okay, great, if this doesn't work, we're going to do the next one and the next one. That is just important to know about fertility in general. Yeah, no, that is really important. And I think we're going to get into kind of some of that with some of these myths. Oh, God. So where do these myths come from? TikTok? These myths come from actually our listeners who just wrote them in. Where do they hear it from? Like this is, I'm always sure TikTok, I'm sure this. Honestly, there were 2 that were so fucked up, honestly, that I refused to. Can we curse on this podcast? Oh yeah, that I refused to. Actually, one of them I put it here, but one guy was just like trolling, and he was one of those like anti-IVF people. You know what I mean? Who's like Jesus. And he said something really fucked up, and I was like, "That's disgusting. I'm not even going to give it legs. I don't know. Maybe I'll tell you after." But I didn't like it. Does anyone like vet these rumors? I guess I will go through it, but I feel like I would just be like, "Who says?" Just so much of this stuff. But that's exactly what we're doing right now. Okay, sure. Okay. IVF myth: you get to pick the way your baby will look, eye color and height. No, no facts at all.
Like,
there.
also, don't you think all of these IVF babies would have blue eyes in that case?
Would be your choice. I feel like I would go green if I had.
Well,
if I could
I
choose,
would go green, but
I would go green or like violet. But no, you can't do that. When we screen embryos, we're screening them for what I call like an information pamphlet, which is their chromosomes, and I want to know that the chromosomes are all present in the right order. There are none that are duplicated, none that are absent. So that is picking up big picture abnormalities. It's not even like the fine print, like the commas and the periods. And that's also important to know when we think about testing of embryos. It's not guaranteeing a perfect pregnancy or perfect baby. You can know the sex or the gender sex of your embryo, but I can't design it for you. I can just say you have 6 and 4 of this and 2 of that. And people can blind them so that they never need to know that. There are things in the pipeline that are direct to consumer right now that are looking for markers of like mental health disorders.
Interesting.
And like diseases that we traditionally think are polygenetic and environmental. That is not ready for prime time, but so therefore I'm sure at some point it's going to be eye color and height if we ever understand the like makeup of the genes that lead to that. This is like an ethically very slippery slope. Right now we're not there. But I'm sure there'll be a point in the future where we could be. And the question is like, what do we do? I am not for eugenics, as most people in my fields would agree.
Right. I will say, if I could have chosen these, I would have chosen my son.
I love that.
Because he's perfect.
I think I would have chosen my kids too.
Yeah.
Yeah, they're pretty adorable.
Oh, but the one thing that this is controversial. You can't pick the gender necessarily.
Can't pick the sex, yeah.
You can't pick the sex, but you can pick the best. Usually you pick the best embryo.
Yeah. I mean, you can pick the sex. I just can't design it.
Correct. So you can't decide the gender, but my egg mixed with my husband's sperm can.
Usually Steven's sperm is going to be
Correct. And if we happen to have, let's say, an equal amount of girls and boys, and you're like, what are we putting in? Do you have a preference? Most people say the healthiest embryo. And some people say, yeah, we only want boys or we only want girls.
Absolutely true.
And that is the one thing.
Yes, that's absolutely true.
Okay, IVF myth, the hormones make you crazy. Not sure that's a myth.
So, I mean, hormones are mood agents, right? We have to remember this. So some people love to have flat hormones. So like birth control pills, they love it. Other people hate that feeling. And we talk about this all the time. I went crazy on birth control pills. It's because you went crazy having like no fluctuation in your hormones. I think the women that are impacted most by this are the ones that are coming right off of oral contraception. So specifically like birth control pills that have both estrogen and progesterone, because you're used to every day being like Groundhog Day hormonally. And then all of a sudden we like rev it up. Some women actually love how they feel when like estrogen is high. And those are women that love being pregnant. It's like you just feel euphoric and you feel really like dialed in and you're sleeping really well. Others hate it. They feel really irritable because they're a little bit too sharp, right? And they're actually really lethargic and like fatigued. So hormones are 100% like mood agents. How they impact people is really individual. And I truly try to say to anybody, just like whatever you're feeling, take it out on me. And I really mean this honestly, because you don't want to like get into a fight with your partner or like quit your job or like isolate your whole family. All these things can happen.
Don't make big decisions.
And the goal is just like, and no one listens to me, but you should not make big decisions because it's absolutely real. But crazy, I dispute. But like impacted, yes.
Yeah, definitely. If it were up to me, I would be injecting myself with estrogen every day.
But this is a good myth though. So people always think that they should be on the lowest dose hormone possible birth control pill. That's not true, right? We all want to be on like low. Crazy, right? If you feel good in estrogen, don't go on the lowest dose estrogen birth control pills. And this is where talking to your gynecologist or like whoever your gynecological provider is really critical to say, this is what I like. I like to feel this way. I don't like to feel this way.
Right.
And they should be able to tailor your contraception. I love talking about contraception.
Yeah, no, I want you to tell me offline which is the best birth control to go on that has the highest estrogen, because I am so curious.
And also in PCOS, it's a different profile too. But yes, we can talk about that offline. Is that what the kids say? Offline.
Okay, another myth. People think it's one and done. I think we know that now.
It's usually not. In order to have one IVF cycle, beget enough embryos for your family size goals, you need a really robust ovarian reserve. And I think what people still don't understand, which is, I feel like all we do is talk about this, but then I think it's combated with like misinformation on TikTok and Instagram, is you can't like design the number of follicles or number of eggs that are retrieved. Each woman is going to have an independent like a number there that is preset by how many eggs your body was born with, and then you're going to allocate a certain quantity. And quantity is pretty immovable. So if your body releases around 12, it's always going to be around 12. And I hear those stories, I'm sure you do, and all of your listeners, that like, well, my friend got 10 once and like 40 another time. Like there can be these weird one-offs. It's just those are the exceptions and not the rule. And I think a lot of people think the exceptions are like reality. So reality is if you're between 30 and 35 and everything is average, you probably have about 15 follicles available. And so in a great cycle, you're going to have 15 eggs. In a more realistic cycle, it's like 9 to 10. So typically that's not like one and done. It's usually going to take us a couple more. But I don't think people are talking about numbers is always hard. But I think people are not as forthcoming or maybe like honest about real like numbers and outcomes because it feels like everyone's talking about like such high numbers and that's average or normal. What they have is therefore less than, which I can tell you as someone does this day in, day out, it's just not real.
Right. That's part of why I don't share how many I got because it like I wonder if people think I'm not sharing because it's such a big number. But in the reality, like it might not be. And maybe that's just because we're all so different and it's just not the same. It's like why you don't share like how many carats your engagement
or like
ring
how much
is.
you
like,
weigh. Like I
or
feel
how
like
much you
we
weigh.
should like that's a secret.
Right. Like no one needs to know what size jeans I wear.
No.
We're good.
But it's
size 23. I was just kidding, by the way.
100% kidding. Okay.
I'm dying. We literally both said that at the same time.
We're both New Yorkers. We're like, but by the way, it's super skinny.
Okay. Myth about IVF that it equals a baby.
No. And this is the really hard part, which is especially if you have like infertility, sometimes this is not the path. And when to make that decision is really challenging. And there's a couple of things that have to happen for a doctor to essentially say like, I don't see this heading the direction you want. But no, like sometimes you don't have a healthy embryo and you can't make any more healthy embryos. And so IVF is not going to be what we call like autologous tissue. So your eggs or like your partner's sperm. Usually there's always a path to a pregnancy. It may be adoption. It may be egg donation or sperm donation. And it's just, I try to always say to my patients, like, what's the goal, right? Is the goal to have a family? Does it matter how you achieve that goal? Like what's important? But talking about using like a different source of like egg or sperm or a uterus is a really hard like pill to swallow. And so also really important to feel comfortable with your team. And like sometimes my patients raise it before I do because I'm like skittish about it. And it feels like such a relief to me when someone's like, what do you think about this? It's like, I'm so glad that's on your mind. Let's like talk about all this in parallel. But no, IVF isn't always a baby.
Do you have a threshold? So let's say I came in and I, pre-Zachary, we did 3 failed transfers. Is that a threshold in which you will say, I like floating the idea of maybe this not being the exact path, but you'll get a baby, like, or is it we're 20 times in? Like,
definitely not 20,
what's it going to take?
There's a medium. There's like a happy medium there. And it also depends, same thing with when you're making like follicles and embryos. It depends on the reason, like the why things aren't working. So let's say it's because I just can't get your ovaries to listen to me. So we can't grow a lining. Fine. I don't need your ovaries anymore. We'll just take like hormones. We'll take estrogen and we'll build it that way. What if it's because you have big fibroids in the uterus and so I can't see it? We'll have surgery. So there are many different paths, but if everything is optimized and so uterine tissues developing and there is not like a magic thickness, that's also like a myth out there. But if the tissue is optimized, the embryo transfers straightforward, there's nothing I can point you to say, I can actually improve this. For me, I'm talking about thinking about a carrier at the 5th transfer and really saying, hey, at the 6th we need to. And that just comes from like a lot of data, which is to say at some point, even if we're surprised, it's a uterine factor. And I just had this conversation with someone the other day and I thought that we were on the same page and she was lovely, but sort of taken aback. And I was like, okay, like, so take a minute with this. But I think everything is optimized except this one variable. And I think if we just change this variable, which I know is giving up a lot of like who you identify with as a mother, you will have a baby. So like, are we ready to get there? But that is tough. But typically if like we're not pregnant by the 5th transfer, we're starting to think like we're really at the end of that bell curve. General stats, first embryo transfers, live birth rates are like 68 Second embryo transfers, like cumulative probability, it's about like 85%. And so that's the point at which I'm usually pausing and going like, what am I missing, right? What do we need to do? And then third embryo transfers, more than 90% of like patients or couples are pregnant at that point. So usually by like the third one, we're there. And if we're not, we're having different conversations about like, what are we bracing and ready for? Because now we're in new territory.
So insurance believes that if you've had one baby, you've cured your infertility.
Is that true?
Do you believe that though as well?
No, because you can always have like secondary infertility, which is exceedingly common. Insurance believes that if they make enough embryos for you to have one baby, they've treated disease because they're not interested in like your family size goals. So there are some insurances that are like, if you have one embryo, you have to transfer it. If you're like, but I want to have like 3 kids and I'm 39, that's not going to work. But no, I think obviously like infertility can come up at any point. Even if you've had like 4 kids, you can have infertility because when we talked about this, C-sections are uterine surgery. So it changes your anatomy. It changes lots of things.
Another reason I thought it was my fault.
Which is 1,000% not the case. C-sections are necessary procedures.
Yeah. Yeah.
You still don't believe me. I can
I
feel you not believing me.
No, I do. I do. I am curious. This is just a question about Spring. Does Spring have a rule about like if someone's dealing with secondary infertility, meaning they already have a baby, can they bring that baby into the waiting room? I'm so curious.
This is such a hot topic and it's really hard because I absolutely understand how hard childcare is, how hard like getting to your doctor is and all these things, but I'm very sensitive to like the population in that waiting room. And you never know who's like longing for that child who's going through a loss and have a pregnancy. And so we say no, babies, no children. If we're like in a pinch and someone's there, we just try to like usher you to a room that is kind of far away from the waiting room. But our policy is no.
It's really interesting.
And it's hard. And we try to keep our waiting room pretty like empty if we can. We try to run really on time because I don't want anybody to, and we talked about this, I don't want anyone to like be in there and like see their colleagues or like their sister-in-law, they're not talking about it. Like this is to be shared when you want to share it, but you shouldn't like pick it up in the waiting room, which is a part of the reason I feel really strongly about like scheduled visits and punctuality.
Right.
But that said, like, I don't know, some people like to have people in there and they feel like camaraderie, but babies in general, people always will say something to me like, oh, like, you know, so-and-so has this person there. Like, can we move them?
It's really hard, I will say, if you're listening and you're going through a fertility journey, fertility doctor waiting room etiquette. Try to just like, if you run into someone you know, try to just like smile at them. Try not to go
smile.
up.
Did you make eye contact? I feel like I would
I think it depends on who the person is, but the best interactions that Steven and I have had in the Spring waiting room was a smile, and then afterwards the couple sent Steven a heart via text, which I thought was very cute. And like we sent a heart back.
Okay. But no discussion about like what was happening.
No discussion. Honestly, we were kind of following their lead, and I think that's the best way to go. Certainly, if you're going to say hi to them in the lobby is probably better than the waiting room.
Yeah. I mean, we talk about this all the time as like providers at Spring, which is like, how much community do you want to build and foster? Do you want to make like events available for people to do like shots together? Do you want to have like classes where people that are in cycle at a given month can meet each other and like maybe like find a friend and go through? Because a lot of, particularly fertility preservation, is lonely, right? When women are freezing their eggs, or typically don't have a lot of like strong support. Sometimes they do, but usually they don't. And so those are my patients that I think actually like to find somebody
that
that's
I
like,
agree with.
But I still, and maybe because I'm such like a curmudgeon New Yorker, I still wouldn't talk to anybody. Like I wouldn't want that.
Well, maybe if you were freezing your eggs, but
I don't know.
Maybe if you were freezing your eggs and you were single and like wanted some single people to like, you know, when we did our event, that crew, like that community really showed up. Our event at
like forever ago.
Yeah, and I think a lot of women bonded at that event. But I will say, there are 2 types of couples going through IVF. There's the couple that has no reason, not only like reason to be secretive, but is just open about it and wants people to know they're going through it so that they're not alone. And then there's a couple that wants it to be the biggest secret in the world, that even after their kid comes, they will not tell anyone how it happened. And you know what? that's not me, but
Yeah.
I have to empathize because clearly something has really made them believe that it's not okay or wrong. You know what I mean?
Yeah.
And like, I found out recently a friend went through IVF to have one of their babies. And I was like, wow, I had no idea. And the friend was like, I think that's the point. Like, I think that was her goal, is that so no one would have any idea. And I was like, you know what? That some people are that way still to this day, but that's why I find it so important to continue trying to get the stigma to not be a thing.
I mean, what had you deciding to share so much? I know we've talked about it, but what has, like, as I said to you, it's really impactful to be sharing this like in the moment, right? Because everything that you're feeling, sort of like the uncertainties, the vulnerabilities, the fear, anger, all of it is what I see every single day. And I feel like it's just never spoken about. So when you're feeling it, you feel like there's something wrong with you. You're like really isolated and it's really challenging. But I think to like be this real is super rare.
Yeah.
Because it, we literally don't know what's going to happen.
No,
and
it's true.
That is like just removing all sort of like cover. And I think people, for reasons I still don't understand, which I know makes me sound like such like a Pollyanna, there's so much like shame around this. And I don't get it. And I try to get it, but I don't know why it matters how you build your family.
There's also like IVF competition almost within IVF. So for example, if when I did my second transfer to have another child, it worked on the first time, people in the IVF community who might be, not having as good of a time, I'd say, well, you barely did IVF. You're not a real person who has gone through IVF because it works for you every time.
Right.
There's a lot of that in the community as well. And to me, I hear that and I'm like, it's the same thing as pregnancy. Like I've said this before, no one gets out unscathed in some way or another. Like maybe I had my fertility issue, maybe you had no fertility issue, but maybe you had postpartum depression.
Absolutely.
Someone's going to get hit with something. So like, why does it have to be like a dick measuring contest of like, oh, that worked the first time for you, so you're not a real infertility person.
Like,
it's
why?
like, yeah.
You're so right about that. I just don't. There are like IVF warriors that I have a ton of respect for, but I would hope that they're not like invalidating the people that have it like easy.
Exactly.
Like, no one has it easy to your point. And that
like, it wasn't cheaper. I mean, maybe cheaper in that I didn't have to do, this.
No, it's
this
all
one
ridiculously
thing.
Exactly.
Exactly. It's
That's
hard
an interesting
for everyone.
point. And the other thing you said a long time ago, which always resonates with me, is this idea that like having infertility like wasn't going to be part of your identity. That like you weren't that girl. And I think about that all the time because I see people be sort of like taken aback.
Yeah.
Right. That, oh, like, well, why didn't it like go perfectly? Like I thought it was going to be like 80%. Why am I only 60%? And I'm like, 60% is fantastic. Like what's going on? But they just didn't think it would be them despite like conversations and hopefully like understanding of situations. But it's really shocking that this particular issue hits people's core.
Oh, like, totally. I mean, because there are people on the internet that are saying that fertility is up to them.
What does that mean?
There are women out there saying if you can't get pregnant, that is your fault. Like, and then there's people saying, the like religious people who are saying, if you don't get pregnant, you're not meant to have a child. Like if you don't get pregnant, and it's terrible. But you internalize that.
Religion
and I'm not religious at all. And I once had a thought when I was like 26 about someone trying to get pregnant who couldn't.
Yeah.
I was like, maybe they're, God's telling them that they're not supposed to be in that relationship. I literally said that to a friend once.
Oh, gosh.
And now I'm like, what a fucking idiot. I mean, I think that about most of the things that I said and thought in my 20s, but like, it's just crazy. Okay.
Yeah, I think that's really, that's crazy.
Crazy. Back to the myths. This is one that I hated that I didn't want to put on it, but someone said it causes cancer.
It really doesn't.
Yeah, it
and so, I mean, like, worst part about that is our like benchmark for that is pregnancy. So there's not a state that your hormones are elevated for longer than pregnancy.
Right.
And so we use that constantly to say, okay, what are the risks of breast cancer, uterine cancer, ovarian cancer? And if pregnancy is like the worst and we sign up for it like happily, where does like everything I do come in? And know that when you have elevated hormones, it's brief. It's like 10 10 to 12 days, right? And it never gets as high as it will get in pregnancy.
Right.
And there's lots of studies on this. And so typically, the studies are a little bit older, but we think about like an egg donation population. So women who have lots of follicles in their ovaries, so a lot of cellular turnover. In that population, we're like, okay, 6 cycles and that's it. Because after 6 cycles, you can have an increased risk of not ovarian cancer, but what's called like a borderline tumor, which sounds scary, but it's just a gnarly cyst. No one wants it, but it's not even ovarian cancer. And so I try to use that as like a guide to say, okay, if we're at this point, but that doesn't apply to my patients who are like growing 2 follicles a cycle. Those patients need a lot of cycles. 6 is not going to cut it to achieve their goal. So all of this is weighed and really critical to talk to like your team about like what are the risks, what are the individual risks for you, what if you have a family history of breast cancer, like lots of things like playing a role in this conversation. But IVF by itself does not increase your risk of cancer.
Right. And you guys know everyone's medical history before you're going into this. So you know how to tailor it to make sure you're not doing anything.
And these are scans are typically not done, right? Like usually women are not having like their uteri scanned or their ovaries.
Right.
And so I I have definitely picked up like ovarian cancers in like 20-ish year olds who are freezing their eggs. I was like, that's not supposed to be there. Like follow this up. So there's that too.
Right. If anything,
I'm curing cancer.
Exactly.
Yeah, that's all I do every day.
Okay. Myth, you're more likely to have twins.
No, not from IVF. And I should say not if you're doing like embryo testing. So most centers have now really moved to what's called like elective single embryo transfer, which means you have an embryo that's like a day 5, 6, 7. So blastocyst or like a week-old embryo, and you have pre-screened the cells to confirm that they are chromosomally balanced. And with that, you have a very high chance of having a singleton pregnancy. Back in the day when we didn't do as much embryo testing.
They used to just throw the embryos in. See what sticks.
And some centers still do, and some people still need it. And like, you know, we do high number embryo transfers for a certain population, right? But it's not like the standard, but it's by no means are we like really like in this very narrow box if we only do this. It's truly like individual, but most people have single embryo transfers. The treatments that do increase your risk of twins are like actually the inseminations, the IUIs.
Well, I was going to say IUI and just taking Clomid or letrozole on their own.
Those are the ones, because the way that treatment is trying to work is bring more like people to the party. So you want more follicles, more eggs, and sperm closer. So typically you are ovulating like 3 eggs. And if you have a great month, great cycle, everyone finds each other, multiples. It's not that high, but it's like 7%. Yeah. It's not small.
Yeah. Honestly, it sounds good. I'm down to have
stop
twins.
It. That's also what I hear. Like it's just
time.
Twins. No.
I was so anti it the first time, but now I'm like, if we want 3, it's a 2-in-1 deal.
Do you want 3?
I don't know.
Oh God.
I might have to move to a farm.
I was going to say New York City is
Ohio.
hard to have 3.
Okay. Myth. Don't think it's a myth, honestly, for me, but you gain weight.
So the myth of that is that like you gain weight that you're never going to lose, right? During IVF, because your ovaries are making more follicles than typical, that follicle is just full of water. That's all it is. And so yes, in the middle of your cycle, you literally have water weight. Of course you do. And maybe like water retention elsewhere too. But usually most women within 2 weeks of their retrievals are pretty much back to themselves.
Yeah.
I also think some people like are really regimented, and then you go on hormones and you're starving and you eat more. And so you're eating more, and that's why you're gaining weight. It's not necessarily because like the injections themselves. You just are like eating burgers, and you know that I support that wholeheartedly. So
you show earlier if you get pregnant from IVF.
No, but that may be like some practices, and typically not the coasts, so not like West Coast, East Coast, but are still doing embryo transfers in the same cycle that you're doing your retrieval.
So that's called a live transfer.
It's called a fresh transfer. I love live, but fresh, which means it's not frozen.
Yeah.
Typically not tested. And so you're doing
live transfer. We're live streaming.
We're live streaming the embryo transfer. And so in that setting, your hormones have not been able to like crash and reset. And so you probably do show. You feel pregnant faster, and I'm sure you show sooner. But that's not the standard so much anymore.
Why don't you guys do live?
We do. I love live. We do fresh transfers, but it's for specific populations. So you You know what ovarian hyperstimulation syndrome is,
Yes,
right?
yes.
But ovarian hyperstimulation syndrome can happen after an embryo transfer because essentially what it means is your hormones continue to propagate. And so if you get pregnant shortly after an IVF cycle, your hormones can never go down and you have what's called late hyperstimulation syndrome. So we all have strict criteria for when you could do a fresh transfer. And
But if you're at risk for that, you wouldn't do it.
You wouldn't, because it's like if your estrogen level is more than 2,500, if you have more than like 15 follicles, like it's these things that most people are like, okay, that can't be you. And a fresh embryo transfer has like lower success rates depending on the population. So it really only serves women well if you're less than 35 or you can't make embryos in the lab. And we're just trying to like do something and give everything a chance.
Okay. And last myth is it's rare to have insurance cover IVF.
No, in New York State, it's a mandated state.
But there are rules. And we talked about this on the last episode. You have to be 35. You have to be trying for over a year.
Right. That's true. You have to have infertility.
These might just be the rules on my shitty insurance. There could be better rules on other insurance.
Right. Yeah.
But the rules on Aetna, if you're listening.
Oh, good. Just right on the bus.
Uh-huh. You have to be trying for over a year.
Yeah.
You have to be 35. And there's like some other stipulation that I forget.
If you're less than 35, you have to try for a year. But what plans like Aetna, and every plan's a little bit different. Again, they're treating infertility. So they won't just give you IVF. They'll say try inseminations for 3 months.
Right.
Or
Yes.
6
You
months.
have to have tried so and so.
Which may not be like your goal. So this is where commercial insurance and your goals may not always align. And Aetna in particular might have a policy where if you have one healthy embryo, they've done you transfer that embryo and move on. So insurance plans are complicated, but most people in New York State do have some kind of coverage, but the coverage is variable. You can have $1,000 and that's not going to get you very far. So vetting that out is critical. Talking to your HR department if it's not a good plan is important if you feel comfortable doing so. And then using it to the best of your ability, get the labs covered, get the medications covered. But IVF is definitely covered in New York State. It's just not robustly covered, I would say.
I could talk to you all day.
I know. I feel but here's my question for you, since you're a social media guru, is why do people just believe what's on social media? Because I swear I spend most of my days combating 22-year-olds on TikTok. And I just don't understand why we don't.
It's like in Josie and the Pussycats when they would wear those headphones and there would be
Josie
subliminal.
Moran was in? Was she in the Pussycats?
No, Josie and the Pussycat. Tara Reid and Parker Posey.
Parker Posey?
Oh, it was the best movie of all time. You have to watch it with your daughter. She'll love it.
She'll love it.
But basically, you wear these headphones and there's subliminal messages that they're trying to send you from the PRs of America.
Okay.
And that is Instagram today, I swear. And it's just you open your Instagram and you're all of a sudden watching a reel of a podcast where a woman's like, fertility is your fault. And you don't necessarily believe it. You don't want to believe it, but then you're hearing that again in the shower later. And you're like, I can't not hear it because I was served it. You know what I'm saying?
I just don't understand we don't. We just believe it. I spend so much of my day combating these just dishonest posts out there about, and I'm well, I think they're just trying to sell you that supplement. I don't think 100%. It actually.
Everything is.
But why did we get into this tunnel vision where very smart women tell me that it's because they didn't eat cod oil? And I was I don't know why you think cod oil is going to help you.
No, it's really crazy. I mean, that's a whole other.
I feel so. It makes my heart hurt. I have to tell you.
Me too.
I know.
But I love you. I'm so happy that you came on. Manifesting good things for the future.
Love that.
And if somebody wants a consultation at Spring with you, even though your wait list is probably
I just hate this part.
Beyond, where can they?
They can find me. I probably our website, Lindsay. Right? I don't know. You can look at our website at Spring Fertility. And this is the first day of National Fertility Awareness Week. And I have decided, get ready for this, drum roll, that I am going to post on Instagram.
Oh my God.
I am going to start to do this,
it.
Which I traditionally really dislike, but I'm going to try to start to do it. But yes, you can find me at Spring Fertility. There are 4 of us currently. It's a fantastic practice. They have fantastic colleagues. Everyone is great.
They're amazing.
Great care.
You'll be in good hands.
Yeah.
Check it out.
Oh, cool. All right, catch up. See you later.
Bye.